Our next session, I would like to invite Dr. Parakshe, Dr. Kamaldeep Chawla, Dr. Dignesh Vasawa as chairperson, Dr. Bikramadit Padi, Dr. Viral Gandhi, and Dr. Anand Ahuja as moderators. Over to chairpersons for the next session. To introduce our speakers, over to chairperson. Please.
Welcome all of you to this academic fiesta. It is always honor and privilege to be part of Cardiocon. Congratulations and thank you to Kamal and the team of the cardiologists who are instrumental behind this academics. Dr. Dipesh Shah, he is the chief cardiovascular surgeon at and surgical director of heart transplant at Richmond, and he has extensive experience in cardiac transplantation as well as ventricular assist devices. And he will put forward his case for this particular situation of refractory heart failure and stage heart disease, where the 3 times admissions in last six months and not amenable to other medical management with normal pulmonary artery pressures. He will have his case for ventricular assist devices against Dr. Nayak, who will propose heart transplant as his modality of treatment of choice. As we all know, ventricular assist devices initially started as a bridge to transplant, and with the advancement in the technology and all, nowadays it is also considered for destination therapy. Let's see what both the speakers have to say. I invite Dr. Dipesh along with all my other chair colleagues as well as moderators. Dr. Shah, thank you.
Thank you, Dr. Shah. Everybody can hear me clearly? Yeah. Good morning from Richmond, and good evening to India. Thank you, Kamal, for inviting me to this wonderful platform, and in the presence of all these eminent dignitaries and all experienced cardiologists and few of my surgeon colleagues. Without much ado, I would try to present my case because of the time constraints. I'm going to be speaking in favor of LVAD as a bridge or a destination therapy for this case on hand. Just going right to the case, this is a 60-year-old female presented with the class 4 symptoms, recurrent hospitalizations. Most importantly, on exam, they found raised JVP and grade 3 Pansystolic murmur in mitral area. You see the evidence of cardiomyopathy on the EKG with the QS in V2 to V4 and then deep T inversion in V2 to V5, which points to the case being a chronic heart failure case. Yeah, the echo showed typical findings of a dilated cardiomyopathy. Sounds like bilateral ventricular enlargement, probably, certainly dilated LV, moderate MR, and mild PAH. Coronary angiogram was 6 months back, but it was normal, so we'll accept it to make decisions. The right heart cath at the time showed PVR of pre-Wood units, and I'm assuming it was 6 months back as well. So considering the presentation, things may have changed from the perspective of the right heart. So in short, this patient is a chronic heart failure patient on a downslide with recurrent CHF readmissions. Importantly, the pulmonary edema every time she presents, and that's not a good sign. And with that, it is associated with worsening renal function. At the time, the renal function was found to be, I believe it was eGFR was 50. So I expect that the renal function is worse this time. The other most important factor was that this lady has blood group of O negative. And in next few slides, I will show how that is so important in this case. And the second most important point is the raised GABP and the declining renal function. You all know this. I don't need to dive into the details of cardiorenal syndromes, but the most relevant to our discussion today is the chronic cardiorenal syndrome, where it's the heart causing the renal failure. Because the increased renal pressure then leads to increased interstitial pressure, collapse in tubules, low urine output, volume overload, so on and so forth. We all know the treatment algorithm, how we treat these patients. You guys typically treat them in the initial stages, and how, as the heart failure advances, we have reached the final stage. It is the third pyramid that's now need for advanced heart failure therapies, which is transplant or an LVAD. This slide has been taken from a presentation by Daman et al. From the Journal of American College of Cardiology, which they clearly showed that in the CKD stage 1 and 3, once the medical therapy has failed, then LVAD has an important role to play to bring back the renal function, so that these patients can either become the candidates for the transplant, or they can continue with the destination therapy if they so choose. Impact of low GFR. Now say, what is the other option? The other option is heart transplantation. So we just hypothesize if this patient go on to get a heart transplant, then they have a very high risk of bad outcomes. They all go on to get they are very high risk for end-stage renal disease and go on to get the chronic renal replacement therapy or either permanent dialysis. And that doesn't bode well for their quality of life. If you look at the results in this slide, the end-stage renal disease, the hazard was 1.4 if the eGFR was more than 60, but as it goes down, the hazard ratio goes up. It's almost double and almost 3 times once it falls below the 30 mils per minute. eGFR at the transplant, again, it also decreases the survival. The mortality increases with worsening eGFR. And as you can see, the death during the follow-up increased progressively from 30 to 45% as the eGFR decreased from more than 60 to less than 30 mils per minute per 1.73 meters square. Patient survival, as you follow these patients up, you'll find that their survival also keeps declining. So it is very important that when we see these patients, we share this information with them about what's the best options for them. Maybe if you expect that their eGFR is going to improve, then it's okay to proceed with listing. But if you think that it's not going to improve, then it's better to bridge them with an LVAD. Again, this paper concluded by saying that if your eGFR is less than 70, then you have the highest risk of poor survival. This comes to the second point, and I hope this video plays. This is for the Star Wars fanatics. No, I hope not. I'm still with the jet, I can tell you. It's a Sith legend. Darth Vader, Dark Lord of the Sith, so powerful and so wise, he would use the Force to influence the midichlorians. He had such a number of yards that even the ones who cared about it, they died. He could actually save people from that. So this talks about the Chancellor Palpatine in this Star Wars Episode 3 about how this God Sidious had an amazing power to save his loved one's life, but cannot save his own lives. In the end, he was killed by his apprentice, who he taught everything. And I think that the blood group O are in the similar category, that they are universal donors, but they struggle to find the hearts or the donor organs for themselves. And so that's why I feel like this is relevant. This meme is relevant to the blood type O recipients. So this lady, ironic that she could save other people by being a universal donor, but not herself. So that's why I want to focus on the blood type in this case. It's very important. Again, I want to make a disclaimer for our panel that my presentation pertains. This is from the U.S. perspective. I know that the transplant programs in India are relatively newer, but so the incidence, the number of transplant programs are also relatively fewer compared to Europe and the United States. So the number of the organ availability may be different, the competition may be different, and the criteria may be different. So I acknowledge that. This is from the ASIO journal from 2020. So it's not fair for the blood type O. So in this paper, about 3 million blood donors, about 46% are blood type O, and AB type is only 4.1%. And in the further deep diving into the UNOS data, they found that the AB type is 5 times more likely to get a heart than the type O, and the average wait time for the blood type O is about 22 months compared to the type AB. So let's see how the blood type also affects the outcomes in the heart transplantation. So if you look at the bottom of this slide, the hazard ratio for death just after listing the type O is higher, and it is statistically significant compared to blood type A, AB, or B. None of them are statistically significant. So having a blood type O does matter. It increases your risk of dying on list or dying after transplant. Why is that? In fact, blood type O is protective in terms of other cardiovascular diseases, but still in the matters of heart failure, it is a huge disadvantage for these patients. From, again, the biocompatibility standpoint, they wait longer, they have a higher number of adverse outcomes. And also another unfair point is that about 23.8% of the O hearts go to the non-O recipients. So that's just so unfair. But for now, that's the allocation policy we have. So I would like to know from the world if there is a different allocation regard to blood group in India. But again, how do we fix this? How do we fix this inequality? How do we fix this discrimination? And I think the answer is in LVAD. Again, from both the renal failure as well as the blood type discrepancy. So it was found that once you put the patient on LVAD, then the benefits are similar, but also that the relative benefits are similar, but also the outcomes are similar for all the blood groups once you put the VAD in. So it takes away the disadvantage from having the blood type O, and these patients can then safely wait on the wait list without having the wait list mortality. Again, about 49% of VADs are being implanted as a bridge to transplant or a candidacy to transplantation. And the use of VAD is associated with increased wait list survival, meaning the patients are able to wait, being stable on the wait list without having any adverse outcome or without dying. Again, it is, in the summary, O is a significant risk factor for adverse outcomes, but once it should be evaluated, these patients should be evaluated for early VAD implantation to improve their outcomes. This is another, just I wanted to mention the Momentum 3 trial, which concluded with the HeartMate 3, which is the latest device, LVAD device, which is beneficial to, which is more, which has got less incidence of the stroke and other complications compared to the HeartMate 2. But most importantly, they ended up removing the designation of destination therapy or bridge to transplant. So it's just because it's just one indication now, and they're trying to remove the designation as destination therapy. It's about improving the quality of life of the patient while they wait for either heart or if they don't qualify for the transplant, then they can just write it out. But it does improve the NYHA class. It does improve the 6-minute walk distance, all the health-related questionnaires, and European quality of life. All these were known to improve on the LVAD therapy. I want to thank the Cardicon and Dr. Sharma for this opportunity. It's my pleasure being in with this esteemed company. Thank you.
Parag bhai, you need to unmute.
Sir, you have to unmute yourself.
Thank you very much, Dr. Shah, for this crisp presentation. And now let us see what Dr. Nayak has to put forward for his case of heart transplantation as the preferred treatment of choice for this particular patient and situation. Dr. Nayak, please. Thank you.
Yeah, good evening, everyone. Thank you very much, Kamal and the team of Cardiocon for this wonderful opportunity. Dipesh, hi, how are you? Hope all well there. Congratulations for another family member.
Thanks, Tawa.
Yeah. So just, I'm like you. Okay. Let me. Okay. So, Parag bhai, how are you? All well?
I'm good. I'm good. Thank you.
Am I audible properly?
You're perfectly audible and visible to your slides. We can see. Please.
Thank you. So, thank you very much for wonderful presentation, Dipesh. I just want to commit one thing here. This today's debate is not to fight actually, but to understand both super modalities, because still India is evolving actually in both things. So it is better to understand. Clinical data has already Dipesh published. Is a known case of established heart failure, and I agree that's O negative blood group. Just PVR is slightly higher side, and eGFR is 50 ml. It is on the lower side. So these are three factors actually, which is more of a determinant for these ladies, whether we should offer heart transplant or VAD. Before we go, just the wonderful picture of history on the left side. So Michael Debicki with first LVAD, and the second on the right side, Christian Bernard, his first patient of heart transplant. It is always nice to see this history point of view. As I said today, just I'm going to stick a little bit of on informative side and lesser on debate side. So my few slides are going to be just on the on this kind of information. So this is the indication of a heart transplant or VAD, you can say. According to guidelines, it is any refractory cardiac shock with IABP or ventricular assist device, any cardiac shock which is requiring continuous IV inotropic support, peak VO2 less than 10 ml per kg per minute, NYHA class 3-4 with optimized medical therapy, recurrent life-threatening arrhythmias despite of AICD or antiarrhythmic medicines or ablations, end-stage congenital heart failure patients without evidence of pulmonary hypertension and refractory angina with without potential medical surgical therapy options. So these all are patients actually who falls, and these patients, they need either heart transplant or VAD. Just in a brief, if we look at advantage and disadvantage of both modalities, heart transplant patients, they have a better, longer life. Most heart transplant patients, they enjoy better quality of life. They have a high energy levels. They have improved general well-being, and work and travel is quite easy. When we look at a VAD, as Dipesh shared, immediate availability is the most striking advantage of VADs, and we can always plan the intervention actually. Disadvantage, again, as he mentioned, lack of donors, and particularly for this patient, O negative blood group, it is definitely is going to be a difficult actually to get a good donor for her. Otherwise, immunosuppression, transplant, vasculopathy, infection, malignancies, as we all know. A problem with VAD, actually, it's very easy to say the word, but again, the patient, they become totally dependent on the device. We need continuous power requirement. They have to carry a bag. They have to always make sure that power is available, particularly in the night. Anticoagulation is a little bit of a more issue sometimes, and we have to check it very vigilantly because stroke and GI bleed, sometimes it happens, they are fatal. So there are so many publications has been happened for heart transplant because just we are doing since last 50 years. So I'm not going to speak everything, but this is one of the paper actually in a circulation heart failure in 2015, which not only shows the results of heart transplant, but they have just tried to establish the results between male and female patients also. And look at the numbers. They've enrolled almost 34,000 patients in the study. Almost 3:1 was the ratio to male and female. And if you look at the results of the transplant, actually, almost 10-year survival is 55 to 60%. There is no much difference between male and female patient. And unfortunately, we don't have any long-term data available for the VADs yet. These are this slide is only for reference. Green color is recommendation. Yellow color is moderate recommendation. And if you look at the recently published ECS guidelines that just published last year, and if we, for the selected advanced heart failure patient, heart transplantation is still level 1 class of recommendation, while the MCS to use as a bridge to transplant or bridge to destination is still moderate recommendation. Even the ACC/AHA guidelines, that's a revised guideline in 2017, says the same thing. Whenever the patient is having refractory NYHA class 3-4, that's stage D, then heart transplant is strongly recommended. Then the VAD is class 2A recommendation. Cost is always an issue. Depends. I know you live in a beautiful country where the money is flowing like anything. These are the paper actually just compared the cost of all therapies. If you look at this red boxes, in USA, heart transplant costs almost 150,000 plus or minus 86,000. But when you just look at the VAD, actually, it's almost 600,000 plus or minus 200,000 bucks more. And this is for VADs actually. So many times with the function of RVD's function, patients, they need the BiVAD actually. Then Dipesh would be always happy to welcome all these patients. In India, till we have to think actually. My heart transplant patient, I just give them budget of almost 20 to 25 lakh, where that is also so many times difficult. And my first VAD patient, the bill costed me 1.2 CR. Dipesh, unfortunately, I haven't received the full money yet. Not going for this detail, this is not related to, but UNOS also has now reduced the number of VADs actually for the acute decompensated heart failure after 2018 guidelines. And now whenever the patients will come with the acute HF, till they just recommending to stabilize with temporary support rather than to go straight for only on the VAD. So I know the donation is an issue. And the surgeons across the globe actually working on that. And this is one more terminology has come up in the picture since last so many years. That is a donation after circulatory death. It's also called DCD. It's a bit of a long topic actually. I've tried to understand in one slide. So basically donation can be happen before death. That is a brain death. Our conventional patient, that's called DBD. And these are the DCD. And we have various types of DCD. And the most common is, in the category 3, where cardiac arrest follows planned withdrawal. So if any patient in ICU on a life supporting system and the family is willing that we don't want to continue this treatment, then these donors, they can become potential donors by just donating the heart. Then we have death on arrival, unsuccessful resuscitation, and cardiac arrest in patient who is brain dead. These all are potential donors where we try to get good heart actually using this organ saving system actually. Now a few more companies are there, but Transmedics was initiator, and I think US FDA approved now. So that's how the society is trying to increase the donors. And these are the number of DCD happening in different countries. And if you see in the UK, since last 10 years, the DCD donors has just jumped like anything. The last year, the numbers were less because of the COVID. So this is one potential is there to increase donors. So just coming to some conclusion, like, now that's a very good paper from ACC in 2015 by Monica. So see what she highlighted is the same thing. The current strategy for any patient with reduced heart failure is always to screen for the transplant first, and then if requires, then only for VAD. Organ availability, as I mentioned, it is a major issue, but then again, just the DCD numbers are going up, so that can help actually to offer heart transplant. VAD support definitely improve the quality of life and survival compared to medical treatment. There are 2 years outcomes, which is definitely comparable with heart transplant, but we don't have any long-term results of VAD. LVAD complications are nasty sometimes, and there are so many innovations are happening actually. So future would be bright with LVAD, I'm pretty sure. So clinical trials, as I said, which needed actually determine which patients benefit most from LVAD versus heart transplant. Again, transplant, we had a very good news a couple of months before. Transplantation, while mature, it has a tremendous potential to growth. Again, modifying xenograft, genetically modifying xenograft transplants, that's only first patient is there, is doing well, I believe. And that could change the future of heart transplant donors. So in summary, for patient who is eligible for transplant but not VAD placement, definitely only transplant is an option, and we can reserve the VAD only in case of emergency. Secondly, for patient eligible for both, either for the transplant or VAD, the VAD placement, if the patient is unstable, like emergency, that is acute decompensated heart failure. And if patient is not fit for the heart transplant, then VAD definitely is the only option, and we can use as a bridge to transplant. If the heart recovers, then we can do heart transplant. If it doesn't recover, then we can continue as a destination therapy. So in given case, definitely O negative blood group remaining a challenge actually to get appropriate donor. I totally agree with Dipesh. Another factor is high PVR, which we can manage. Kamal did not mention about the urine output, though eGFR is on the slightly lower side, but if urine output is adequate, then either VAD or heart transplant, I'm pretty sure that kidneys will become normal if the patient recovers from both the therapies. I still think patient is stable, she is not in hospital, she is not on home milrinone, then I'll wait for at least some time until she becomes sick. If she becomes sick, if she comes back again in emergency or in the hospital with acute symptoms, then certainly VAD. But again, heart transplant is the choice for this patient. This was a picture on the right side. Dipesh sent me a couple of months before.
Yes, getting short of time.
About the xenotransplantation, and I hope the future in India and USA both would be bright with a lot of technologies in VADs also, and in this at the cellular level, this genetically modified pig hearts also. So the patients would be benefited most. Thank you very much for kind attention. As I said, my lecture was more towards to understand to the both modalities actually in appropriate way, because still we are in the infancy level in India, Dipesh, and it is very much important that the patient must get the best treatment. Thank you. Thank you, everyone.
Yeah, I have a question for both the speakers. Can I go ahead? Am I audible?
Yes. Yes, go ahead, sir.
So a very crisp presentation, and both of you putting your point across the board for the given patient. Now, Dr. Dipesh, Dr. Sharma and his team have prepared this case for you, and a heart is available. What would you do? And in the same breath, I would like to ask Dr. Nayak, the same patient has been referred to you and the heart is not available, what would you do?
Yeah, Dipesh, you first.
All right. So let me make sure I understand the question correctly. So you said if the heart is available, what to do?
The same profile patient that has been made by cardiocon team over here. Dr. Sharma is referring you this patient and the heart is available. A donor heart is available. What would you do? And in the same
if I have this same patient, I would not list the patient. So heart would not be available yet, because I want to stabilize the patient first. I want to make sure that the eGFR is declining. I mean, it's improving. So I will list the patient only when the eGFR comes above 60. So before that, I'm not going to list, and so I won't get any hard offer for that.
Yeah, I think the message was pretty clear. I mean, the whole concept of creating that debate was to identify cases who can be listed and who cannot be listed. And it's been a pleasure actually looking how heart transplant has, Dipesh, evolved ever since you left to US. I mean, when you were here with us, Dipesh is a good friend. We've been together for MBBS, and actually Dhaval has been the same. We all have been in the same batch. And I think Dhaval has done some 25, 26 transplants since, and Dipesh is doing a lot of LVADs in US. So it was fantastic to have you guys, but the whole concept was to identify, and I'm really happy that the roto-noto things have actually been streamlined much more. And Dhaval was talking that day about a couple of cases, how they could get a green corridor and how they are trying to talk about in the waiver of the air ambulances. So I think once that thing sets in, probably more suitable patients. But looking at the patient pool, I think in India do have a lot of scope for LVADs as long as the finances can come into place. Chairpersons, Dr. Kamaldeep, Dr. Anand, your comments, please.
So I'm happy to answer, Dr. Kamaldeep. Just as you said, I agree with Dipesh that eGFR is on slightly lower side, but till I just want to see the urine output. If urine output is good, then maybe 50 ml of like 50 eGFR is, I know it's a borderline, but if adequate urine output, and if I get a heart now for this patient, I might, just go for heart transplant.
So again, my rebuttal is that the 50 GFR was from the last admission. So we don't know that. And these patients tend to deteriorate with the recurrent CHF admission. So who knows, his eGFR is even lower now. It's even less than 30 now at this admission. I wouldn't list this patient.
No, I agree, Dipesh. See, the Dipesh, in India, actually, we cannot stick only with the papers and the numbers. Okay, so there are so many factors actually affect, with the outcome.
So it's not just papers, it's evidence-based practice, right? So
no,
it's not just papers.
Okay, so that's what I'm telling you. It is not like that very randomly I'm going to enroll this patient, but that's what I'm saying. If urine output is good with slightly on the low eGFR, definitely also we should look for the sonography, all other parameters and everything. We must involve a nephrologist. But if it is a borderline, and if you get a chance to get O negative, this particularly I'm talking about O negative. If C would be AB, then I would wait for that.
Dr. Nayak, would you VAD him?
If she doesn't have money actually for LVAD, what you do?
So she has everything.
So you bring up a very important point. So even if you look at the US criteria, if you don't have LVAD, if you don't have LVAD, then you have an option to put the balloon pump. So put the balloon pump, write it out, evaluate after 1 week what it does. I have a patient in ICU right now with the eGFR was 30. After 1 week of being on balloon pump, the eGFR has come up to 70 now. And I don't believe that you can just blindly trust the urine output. If it is 50 ml per hour, then you can just proceed with listing unilaterally. I would involve the nephrologist, go by their expert opinion, follow the labs. The labs are there for a reason, right? So I would not discount the renal failure like that so easily. In the end, what we want is a live patient and well-doing patient, not just because you have a heart available, you're going to put it in. I don't think that's the right approach.
I think Dr. Sharma better to end because
as Dr. Kamaldeep is asking, like if you have everything available, then I totally agree with Dipesh that we should wait. We can, if she deteriorates a little bit more, even if she is not responding to IVP, we can use ECMO or short-term VADs, and we should try to, stabilize her. Okay, but definitely if it is anything but O negative, then we should wait for this patient, not to offer, we should not jump immediately for anything. But since it is O negative, and in mostly, if you say the patient overnight that, just collect, 1 CR, then the patient is 60 years old, the most of the time the family actually goes outside, and what they think actually, is it worth 1 CR? That's the first question comes in the mind. So we also want to do so many things, Dipesh, here. Like just now I admitted one patient, just admitted, and I came here. She's a known case of a muscular dystrophy. She's a young female actually. So the peripheral, the cardiology colleague outside, he has recommended straightforwardly VAD for her, this patient. Okay, so it is not like that I am going to jump on that for that patient for the VAD. Muscular dystrophy is not a contraindication to the heart transplant. There are so many, reports, case studies are there. So definitely we will evaluate this patient for heart transplant first. And if heart transplant is better, if it is possible, feasible, then we'll just offer heart transplant. But if she is not fit for heart transplant, then VAD, as I said, the main advantage of VAD is easily availability, and we can always plan any case according to that.
Yeah, I think we had, for the lack of time, we'll have to end the session here. Thank you very much, Dr. Dipesh, Dr. Dhaval, and all the chairpersons. We had a wonderful session. Thank you, Dr. Parag, Dr. Anand, Dr. Kamaldeep Chawla, for the wonderful presentation and the moderation and chairing of the session. Thank you very much. Thank you.
Thank you, Kamal.
Thank you, Kamal. Thank you, Dr. Shade, and all the panelists.
Thank you.
Thank
you later, Dhaval.